Regional sympathetic dystrophy. Regional sympathetic dystrophy, also known as complex regional pain syndrome, is a chronic pain disorder that results in extreme sensitivity and pain primarily in the limbs without any obvious cause to explain the degree of that pain. Breaking down the word to better understand the complexity of this disorder, regional refers to a specific zone of the body. In this case, this pertains to the patient's limbs. Sim means the union, and this is a nod to the union of the nervous system in the body. Patho is the disease, which refers to the regional sympathetic dystrophy, which is the malfunction of the nervous system. Tic pertains to the disorder itself, and trophy, which is the development of the disorder itself. Regional sympathetic dystrophy isn't fully understood. The formation of it isn't understood yet. It's clear that trauma is the driving force. The process of how it happens and to whom it happens isn't something that is clear to any scientist or doctor. It doesn't have one specific demographic. The cases of RSD arise after pretty much a forceful trauma, such as a crush injury, primarily to the arm or leg, such as sprained ankles, infections, surgeries, repeat surgeries. Something as simple as a heart attack can even lead to RSD. Not every trauma leads to RSD or CRPS, and this is why it's unclear as to why it happens. The one thing that is clear is that dystrophy is exactly like turning on a car engine and leaving it running long after the car has been turned off. Although, like I had mentioned before, there isn't one specific demographic that regional sympathetic dystrophy targets, you will find it prominent in the ages of 40 to 60. You will also find it more prominent among women than men. What medical tests, labs, procedures would be ordered to clarify, identify, or really pinpoint this disease or condition? Let's really dig deep into that. Although there are a lot of medical tests and procedures that can be ordered to clarify and identify this disease or conditions, a lot of that can be used is anti-epileptic drugs that can be treated for neuropathic pain. They basically suppress the excessive rapid fire neurons. antidepressants like amitriptyline and nortriptyline that excessively treat the nerve pain. Physical and occupational therapy, ketamine infusions, which are controversial in the U.S. Steroids in the acute phase come in metered dose packs, 12 or 18 days. Courses, nerve blocks, depending on the area of the body that we're treating, the sympathetic nerve blocks, daily ganglion blocks, facet joint blocks, or a more semi-permanent solution, which is a spinal cord stimulator. So today we have a 26-year-old patient presenting with a prognosis of regional sympathetic dystrophy, also known as complex regional pain syndrome. Patient sustained trauma in the form of a bilateral crush injury after multiple reconstructive and corrective procedures, developed symptoms related to RSD, symptoms in the form of burning sensations in her right and left fingers, hands, wrist, radiating up into her forearm, elbow, biceps, shoulder, into the neck, sensitivity, hypersensitivity to touch, and discoloration in her arms, swelling, and excessive sweating. So what does life with RSD and CRPS look like? I have showed the patient the McGill Pain Index and have explained the pain scale of living with CRPS, and have gone into great detail that life with CRPS is exactly what you make of it. Regional sympathetic dystrophy is known as the suicide disease for a reason. The pain level of someone with RSD reaches beyond natural childbirth, and RSD and CRPS patients are named warriors for a reason. They are natural fighters and fight every single day to make their every day the very best that it can be. Although we have discussed the symptoms that the patient has already uncovered and has felt already, some ongoing symptoms will be unprovoked or spontaneous pain that will be consistent and fluctuate with activity, excessive and prolonged pain after use or contact, changes in skin temperature, changes in skin color, swelling of the affected limb, changes in skin texture, abnormal sweating, nail and hair growth, stiffness in the affected joints, wasting away or excess bone growth, impaired muscle strength and movement. But in the end, RSD and CRPS is what she will make it to be. So, I have CRPS, RSD. Now what? This isn't the end of the road. This is your beginning. It's going to be difficult. The sensitivity that will come will be at times beyond your mental capacity to manage. Hang on to everything you have in you. You will get through every single flare-up. When you feel like you need to cry, cry. When you feel the need to scream, scream. When you feel like you need to stay in bed for the day, do it. Be kind to yourself. Do not feel the need to explain yourself to anyone. People won't understand because you will not look sick. Do not be afraid. You are your own superhero, and you are fighting this battle to win it for yourself. Find a great support system of nurses and doctors that will cheer you on, especially ones that are familiar with this disorder. The course of action and treatment pain management plan that we have going is definitely starting right away with a series of ganglion blocks. We're going to do a series of 4 of them within the span of 3 months. Medications, we're going to start with Nucenta for severe pain. It's a narcotic, so caution, it's a high risk for addiction in high doses. Lyrica is going to neutralize the overactive pain pathways. It's safe. We have no reports of overdose. Gabapentin for the burning sensation felt from the RSD. Opioids, they're controversial, so we're going to pay close attention to the patient's needs for those. And we have discussed the possibility of a spinal cord stimulator, although at the moment the patient wishes not to have any surgical procedures. The ganglion block is a nerve block, so it's a concentrated injection of lidocaine to block the sympathetic nerve located on either side of the voice blocks in the neck. This injection will reduce the RSD CRPS symptoms, such as but not limited to burning, swelling, sweating, pain, color changes, and mobility and movement. There are some risks to this procedure that we want her to be aware of. There is a risk of seizure, pneumothorax, which is a collapsed lung, brachial plexus block, which is the numbing of the arm that lasts for hours, a spinal or epidural block, which is weakness, numbing from the neck down, an allergic reaction to the lidocaine, or a nerve damage. Post-procedure things we want her to be aware of is drooping of the eyelid on the injection side, bloodshot eye on the injection side, stuffy nose on the injection side, hoarseness, and temperature increase on injection side. These, of course, will pass by the end of the day. If the patient does decide to go through with the spinal cord stimulator, we will first do a spinal cord stimulator trial. The trial will be done first to be sure that, one, the body will accept the implant, and two, that the spinal cord stimulator will work in stimulating the nerves. The spinal cord stimulator implant is an implanted electrical lead in the epidural pocket directly on the spinal cord. It delivers a low-level electrical impulse that blocks the pain signals from reaching the brain. This relieves chronic pain and is all connected by a battery pack that's implanted in another part of the body. This is chosen by the surgeon that does the surgery, either located in the buttocks, in the fatty portion, or in the back. The internal battery pack is controlled by an exterior remote, and the battery and remote need to be charged. They will be charged separately, and they are stimulated. They do need to be reprogrammed every so often, every 2 to 3 months. Scars will be visible, and the battery will also be visible depending on certain movements. No metal detectors, airport security, or x-rays, so patient does need to be cautious and aware of her surroundings at all times. Surgical risks of a spinal cord stimulator include, but are not limited, unintended movement of leads, breakage of leads, increased pain, infection, battery failure, neurological injury, epidural hematoma, skin erosion, fluctuation in stimulation, jolting, and shocking. The recommendation is the best course of treatment for the future of this invisible illness. We need to choose a course of treatment that works best for the patient, a support system that works best for her. We need to make sure that her mental health is intact. Be sure that her life expectancy is what she expects, the quality of life that she deserves. Make sure she understands the complications that will come with whichever course of treatment she chooses, and make sure that she understands that whatever she chooses has certain expectations that come along with it. Just because you have CRPS and RSD does not mean that your life is going to be impacted in ways that are going to be clearly and 100% debilitating. Your life is going to be harder than others. You will have to find different avenues. You will have to work 10, 11, 12, 100 times harder than someone else in order to get to where you want to go. Your life will be impacted. but you will have a good life. You will find a way to live a wonderful, full, and happy life. It's just going to look different. As long as you listen to your doctors and find an avenue that works for you, take your medications, and be communicative with your doctors, you will find it. Because the person that you're talking to right now and the person that's giving you this advice is living with complex regional pain syndrome and regional sympathetic dystrophy for the past 6 years.